Today my presentation is in FAPDIS algorithm, which is MRI based algorithm and surgical classification. So this approach is mainly help us to decide whether we should go transforaminal or interlaminar endoscopy. So this publication is already published in North American Spine Society. When I was with Dr. Prasad Padgaonkar, we made this FAPDIS algorithm. So starting with first case, this patient has right S1 radiculopathy. If we classify this, it's a alpha S1 level paracentral herniation, superior migration, arthritic facet, and early flaval stenosis. And spinous process is built tilted on the right side. So there is always a doubt whether we should go transforaminal or interlaminar. So we all know that masters can perform this technique with any approach, but for newcomers who are new to the full endoscopic approach, it's very important to identify the symptomatic nerve root and how to tackle out this symptomatic pathology without destabilizing the facet joint or with minimum difficulty during the surgery. So we all know that clinical diagnosis is all important, whether it's a herniation case or stenosis, which is the dermatological pattern, which are the predominant symptoms, whether it's a back pain or leg pain, or the right-sided pathology or the left-sided pathology. So when we see any MRI, what is the location of the symptomatic nerve root, we should see the adequate MRI cuts like upper discal margin cut, lower discal margin cut, discal level cuts, pedicle level cuts, and the body level cuts. When we see the upper discal margin in the MRI, we normally see at the exiting nerve root, whether this compression is because of the tip of SAP or the superior migrated foraminal herniation or the extra foraminal herniation in Lois zone 3 area. When we see the discal level cuts, we normally look at the traversing nerve root. And at the traversing nerve root, we normally see whether it's a compression is a paradiscal, paracentral disc herniation or the least zone 1 or least zone 2 stenosis of the ligamentum flavum. When we see the lower discal margin cut, we normally see at the traversing nerve root whether it is compressed by the medial 1/3 of SAP or the ligamentum flavum stenosis in the least zone 1 or least zone 2 area. We should also see the posterior nerve root compression because of the ligamentum flavum stenosis, whether it's a compression in the lateralis in the zone 1, 2 or 3 area. We also see the anterior pathology, whether it's a disc herniation in the up migrated or the inferior migrated disc herniation. We normally see at the facet joint orientation as well, whether it's a vertical facet or the horizontal facets. So we all know that 360-degree decompression, which can be possible with the full endoscopic approach, whether it's a transforaminal approach, we can handle the extraforaminal foraminal herniation or the paracentral herniation or the central components. When we see the interlaminar endoscopy, we can do the PSLD, which is posterior stenoscopic decompression or the over-the-top decompression. So this 360-degree dural sec decompression can be possible with the endoscopic approach, but which are the factors to be seen in MRI to select the approach, which is very important. So when we classify this FAPDIS algorithm, we should divide the motion segment in the right and the left part. And each motion segment in the right half of the motion segment to be divided into the FAPDIS factors. So what is this FAPDIS factors and which are the component of it? So F means facet orientation, anterior compression, posterior compression, dorsal migration or inferior migration or the superior migration. These all the things to be seen in the MRI to classify this. So when we see the facet orientation, we know that from upper lumbar spine to the lower lumbar spine, facets are vertically to the horizontally orientations. So we normally select the transforaminal approach for the upper lumbar spine or the interlaminar approach for the lower lumbar spine. So we divided this facet orientation into the 4 parts. So F1 is 0 to 25, F2 means 26 to 45, F3 is 46 to 65, and F4 is 66 to 99. And the selection approach, which needs a minimum bone resection for adequate amount of nerve root decompression without stabilizing the facet joint, which has minimum 20-degree angle with the facet inclination. When we see the anterior and the posterior component, that A1 means central herniation, A2 means paracentral, A3 is foraminal herniation, and A4 is extraforaminal herniation. When we see the P1, P2, P3, P4 area, that P1 is central stenosis, P2 is lateral ischial stenosis, P3 is foraminal stenosis in the lower foramen, and the P4 is upper foraminal stenosis, maybe SAP syndrome or far out syndrome. So this is a few example of the cases, like this is A1, A2 type of anterior pathology, this is A2, A3 type of anterior pathology, and this is extraforaminal herniation, which is A3 and A4. When we see the posterior component, this is a central canal and lateral ischial stenosis, so P1, P2. This is a lower foraminal stenosis, which is P3, and this upper foraminal stenosis is P4. We also see the disc migration, whether it's a near or superior inferior migration. So the dorsal migration has been divided into 3 parts. We normally draw a line from the medial most part of the superior articular process, and if the herniation is near to it, it's a near herniation. If herniation is far from it, it's a far herniation. And if it is a soft and if it's a hard, then it's calcified, then it is considered to be a far hard herniation. We should classify the inferior herniation as well, whether it's a near herniation like this. This is far herniation. And this is a superior herniation, whether it's a near, far, or very far. So after classify all the factors, we should classify the scoring if there is a transforaminal or interlaminar score, and based on the scoring approach, if the difference between the two score is 0 to 0.5, then it's a surgeon's choice whether we should go for transforaminal interlaminar approach, or whether it's a difference is more than 1, then approach will be decided which is a higher score. So let's see few cases. This patient is a L5 radiculopathy. It's a stable joint. And when we classify the FAPDIS factors, these are F2 type of facets, A1, A2 pathology, no posterior compression, dorsal near migration, inferior near migration, no superior migration. So the transforaminal interlaminar score is 5, 4.5. So we did transforaminal endoscopy, and this is the post-operative MRI. Same as well, this is a right L5 radiculopathy. If we consider the FAPDIS factors, it's a F2 type of facets, A1, A2 pathology, A3 pathology, no lateral stenosis, that means P2, and dorsal near migration, inferior near migration, and no superior migration. The score is transforaminal 6.5 by 6. So we decided to go for transforaminal approach, and we did transforaminal endoscopy in this. Another MRI where we saw the FAPDIS factors is the F3 type of horizontal facets, central and the paracentral herniation, the lateral stenosis, dorsal near migration, inferior near migration, and no superior migration. The score is transforaminal interlaminar score is 5 by 5.5. So we decided to go for interlaminar endoscopy, and this is a post-operative MRI. So this new surgical classification of causative compression element needing decompression gives simpler universal nomenclature, and the classification guides to the best available full endoscopic approach for the given pathology. Thank you.